Good afternoon, everybody. Thank you so much, Magda, and it's just great to be here. I appreciate everybody coming to this, I don't know, crowdsourced event for the afternoon for all of you, and I'm very happy to participate. I want to talk about a couple of parts of the borderline personality disorder world that we don't necessarily talk about so much, even though I think as I begin to explain some of our research, it'll make a lot of intuitive sense to you. So I'm going to go ahead and put some slides up on the screen and go ahead and get started. So I'm actually going to talk about just a little bit here in the beginning about the family context of emotion dysregulation and for borderline personality disorder, and try to understand borderline personality disorder as a disorder of emotion dysregulation. And then I'm going to quickly, not go into great detail, but orient you to 5 studies that provide a background for our understanding of suicidality and families, and how suicidality has an enormous impact on parents, and how parents' responses might be able to help reduce or ameliorate the problems of suicidality, those 2 studies at the end, and draw some conclusions that I think are relevant to anybody doing any kind of work with people who are suicidal. So I think everybody understands this, that family members need help, that if you love somebody who's made a suicide attempt or is self-harming or is frankly just suffering a lot, then that we suffer too. That's part of loving somebody, is that. Unfortunately, because of the origins of our understanding or thinking about borderline personality disorder, parents and partners and other family members were vilified and judged and treated rather badly for the first 50 years of this diagnosis. Fortunately, that's largely now a thing of the past. I say largely because it still happens sometimes. But when we look at the problems that family members experience, they include burden, psychological, financial burden, social burden, that's not different from the family members' experiences with loved ones who suffer from other very serious problems, whether they're mental health problems or medical problems. Grief and loss is an enormous issue because life doesn't go the way these parents and partners expect or want, and they end up in roles that are not necessarily what they want as caregivers instead of as loved ones and family members. Even if the professional community is now doing a bit better job not stigmatizing family members still get stigmatized by their own families and friends and workplaces and feel very disempowered. Rates of depression and anxiety, substance use are much higher, and they experience very little joy. They tend to blame themselves, even for many things about which they have absolutely no control. And they feel overwhelmed and chaotic, and things are unpredictable, and often experience a lot of dread and stress-related problems, including PTSD, which I'll talk about. And of course, this develops conflicts in relationships in their families. So family members clearly need some help. And in DBT, as well as in many other parts of the mental health world, we understand the concept of interdependence or reciprocity, that what I do affects my loved ones and what my loved ones do affects me. Therefore, we're in a constant cycle of mutual interdependence. And rather than that being a bad thing, it's just true. It's just a fact. And it can have positive impacts for both individuals and their relationships, or it can have negative impacts. So patients can have an impact on their parents and other family members, and they can have parents and other family members, of course, have an impact on patients. So this process that goes back and forth between couple and family distress on the one hand, and individual distress and psychopathology on the other hand, is very well documented. We've understood this in the mental health world as an empirical piece of knowledge since the 1960s, not least of which was the seminal work of Brown and Harris around depression in couples and families, how a depressed person has an impact on their loved ones, and loved ones in turn have an impact on a depressed person. This is no less true for borderline personality disorder. Of course, for a very long time, there's been argument about, well, what is that process? What are those connections? In some ways, that's because the connection is so obvious. We all have had those experiences. If you've ever had a relationship that didn't go well, I'm going to assume that everybody sadly has had that experience, you know that the individuals feel quite miserable when the relationship isn't going well. And similarly, if one individual is suffering enormously, that has a big impact on the relationship. So in dialectical behavior therapy, we say that the link between these two, individual distress and family distress, is an emotion dysregulation process. So let's think about that for just a second. The model we're going to use, and I'm going to just give you the most superficial understanding of that at the moment because we don't have more time, but is that the person with borderline personality disorder or severe emotion dysregulation problems, that individual on the left here is vulnerable to getting dysregulated in that particular social and cultural environment. And they get dysregulated more frequently as a result. Because they are dysregulated more frequently, their distress is not easily understood by other people, and other people mischaracterize their distress, often in very judgmental and pejorative and invalidating ways. And we all know that being invalidated, well, let's just say it's not the thing you wake up in the morning and look most forward to. In fact, we've looked at this as a research issue. So here's a study, the first one I want to just comment on, that we did. We looked at identifying people. This is an experimental study. We brought in ordinary people and gave them kind of ordinary stressors, things to do, problems to solve. Actually, in this case, it was arithmetic problems that they couldn't do in the time we gave them. And their negative emotional arousal on the y-axis here went up very quickly, as you can see. Now, we're measuring this, by the way, not only by their self-report, but we also measured this physiologically. We looked at their skin conductance, their vagal tone, their respiration. And all of these things showed the same response. What they didn't know after they got stressed out is they'd been randomly assigned to have an experimenter, a perfect stranger, either validate their emotional experience or invalidate their emotional experience. So a validating response would be, oh yeah, of course this is stressful. Of course, it's a study, it's designed to be stressful. Or an invalidating response might have been, huh, that's a weird response. I don't understand why you're upset about this. And in fact, continued to give them stressors, kind of hurry up, do this, they got it wrong. And as you can see with the red line, if they're getting invalidated, their stress response stayed the same throughout the whole experiment. But if they got validated by a perfect stranger, even though they were still under duress and the stressors were continuing, their level of stress, their experience of stress went down. Their emotion arousal went down 2/3, 3/4 of the way back to normal. We subsequently replicated this to look at, well, what happens, is it different between people with borderline personality disorders and people who don't have borderline personality disorder? And interestingly, the people with BPD showed exactly this same pattern, precisely this pattern. The only difference is that their baseline level of arousal was almost as high as the peak levels of arousal for people without borderline personality disorder. So this just tells us what we already know, which is that being invalidated is very painful, and being validated is very soothing. So our second study here, actually these are not necessarily in order, is we just were curious about how validation plays out in teens who have severe dysregulation problems that either meet the criteria for borderline personality disorder or would if they were enduring long enough, and compare them to matched community controls. And as you can see here, the parents of the non-clinic teens, the orange, were much more validating and much less invalidating than the parents of the clinic teens. Now, this is not to blame the parents because, of course, the teens themselves were more dysregulated, did not give as much accurate information, and were harder to understand. So this is important. The difference between clinic and non-clinic families is well described, but often just in terms of conflict or criticality. But by looking more precisely at validating and invalidating responses, we have a specific linkage to emotion dysregulation. So Magda mentioned family connections, and we'll come back to that. But one of the things we were interested in doing was looking at what happens in individual treatment. Okay, now this is a study that I'm not going to spend a lot of time on, but this is published, where we compared dialectical behavior therapy with psychodynamic psychotherapy for what we call transitional youth, 18 to 25 years old. There was no family therapy in this particular treatment, either one of them. They both got very good, very well supervised, manualized treatment, DBT or psychodynamic treatment. And as you can see here, the first three, suicidality, on all variables, people got better significantly. However, on all of the outcome variables, patients in DBT got a lot better than they did in the psychodynamic. As you can see, their suicidality, although this is an improvement on the red line, the psychodynamic psychotherapy, it's a bigger improvement for patients in DBT. Although patients got a lot better in terms of being much less depressed from 30 to 15 in psychodynamic treatment, they got even better results from 35 down to 8 in DBT. Social adjustments problems using the social adjustment scale similarly showed significant improvements in psychodynamic treatment, but even bigger and significantly better improvements in DBT. Now, the one I want to call your attention to is this last one, though. Without doing any intervention with parents, in this case, or partners, we can see that family distress also came down in both cases, but came down more significantly in DBT, even though in the follow-up period, 6 months later, there was a slight return in both cases. The endpoints, the end of treatment and the endpoints at follow-up were both much better in both treatments, but significantly more so in DBT. Now, this improvement in family functioning tells us that this transactional model actually works, that when you help an individual do better, it has an improvement, a salutary improvement on their relationship with their loved ones, in this case, mostly parents. So then we decided, well, let's look at what happens with that. So we used a statistical strategy called mediation analysis or hierarchical linear modeling to look at the pathways for improvements in these individuals, saying, okay, regardless of what treatment, we take out all the benefits of the treatment first statistically, and then say, what has to get better regardless of treatment for these young adults, 18 to 25 years old, to show significant improvements. And in fact, what happened was it was fully mediated by family functioning. What that means is that if family functioning didn't improve, regardless of the treatment, these individuals were much less likely to show significant reductions in self-harm and suicidality. Similarly, their social adjustment was much less likely to improve if family functioning didn't improve. Interestingly, family functioning didn't mediate depression outcomes, and depression outcomes were still quite good. So this tells us that not only are families affected by individuals with BPD, but that reciprocity actually happens here, that family functioning gets better, which in turn helps the individual. If family functioning doesn't get better, the individual doesn't get better. This is very powerful and I think very useful to know. So we set about saying, okay, let's evaluate our skills here. We know in DBT there's a whole set of skills that we help patients in DBT learn. And of course, in family DBT, we have to develop a whole set of skills too. So we have developed skills specifically for parents and partners and other loved ones to help them specifically do things that are better for them and better for their loved one with BPD. Now, this last point is crucial, that we don't think that it's a zero-sum situation where if a family member does something that's good for the family member, that's bad for the person with BPD. Quite the contrary. If somebody is suffering themselves, because if they can alleviate their own suffering, they have more resources to give to the other person. And so that's what this reciprocity is telling us, that actually it's not bad for one person to help another. And that's what we set about to do. So Magda mentioned family connections, and there are now many published family connection studies. I'm just going to show you very quickly the first one. So the idea here is that when we bring family members into a family skill environment like family connections, that they show, the family members themselves who participate show enormous improvements. Their grief goes down, their depression goes down, their experience of burden goes down, and their experience of empowerment and mastery goes up. All of these say the same thing. They say that the orange is before family connections, the yellow is at the end, and the green is 6 months later to see, do these improvements endure? We worried that instead, that if it's maybe just a function of being in a group with support, that would be enough. And when the group ended and the support ended, perhaps they would go back to where they started. But in a skill-based program, the skill learning is presumed to continue even after the end of the program. And in fact, that's what all of these results tell us, is that improvements continued into the follow-up period, telling us that the pathway is through learning these family skills. By the way, any of these studies that are published, I can make them available, or you can find them in your academic library. So, but the other question is, well, what about the teens or the young adults or the partners? What about them? If somebody's in family connections, learning family skills, is that actually good for the other person? Is that good for the person with BPD? So what happens, right? I don't know what teens and families look like in Poland, but I imagine they look a lot like this. There's distance, there's reactivity, and this disconnection that's very painful for everybody. So here's our study that I did with my dear friend and colleague Lucy Payne. She and I looked at, okay, what happens when we give good DBT to teenagers? Okay, these are teenagers 14 to 18. Very excellent, state-of-the-art DBT. And we add parent skills randomly. We split the group in half and we randomly give parent skills to half of them. And then, to be fair, we eventually gave the parent skills to the rest, but we gave them to randomly assign half of them to get them right away in treatment. So this is comparing one excellent treatment, DBT, to that same excellent treatment plus parent skills, okay? So, and here's what we see, that in fact, the green in all of these is the parents getting the skills, and the yellow is the parents and their kids who didn't yet get the skills, okay? So, as you can see, the parents who got the skills actually improved quite a bit more in how validating they became and how much less invalidating they showed. And this was actually only over a very short period of time, 6 weeks. So it was very brief. The intervention was over a weekend. We brought people together for an intensive Friday afternoon, all day Saturday, all day Sunday skill training weekend comprehensively. But the kids are all getting good DBT all along. So the parents are showing improvements, reducing invalidation, increasing increasing validation and reducing invalidation. And look what's happening to their kids. Their kids, if their parents are more skillful, are showing much bigger improvements or reductions in their problems with emotion regulation, just in a 6-week period. Now, we can't look at the results longer because after 6 weeks, we gave all the other parents this training. We didn't want to deprive all of the kids of their parents getting the training. So this is extremely good news that again tells us, gee, if we intervene with parents, we get not only is that good for parents, their depression, grief, and burden go down and their empowerment goes up, but their validation also goes up and their invalidation goes down. And that has an immediate impact on their kids. Their kids' problems with emotion go down right away. Now, not only do those things go down, but when we again look at these things statistically, they're directly related to how much more validating or how much less invalidating those parents are. So if the parents got more validating and less invalidating, the kids showed greater improvements at discharge in their emotion regulation and in depression. And for those of you who are statistically minded, I offer this 0.36 and this 0.34. Those are very big factors. They're large effects. What they're saying is that 36 or 34% of the outcome is due to this one thing. That's quite a large effect. Also, teens whose parents participated in the Parent Skills or the Family Connections program showed greater reductions in emotion regulation and depression. All of these were large or at least medium to large effect sizes, meaning they're very efficient interventions. This is essentially a 20-hour, 2.5-day intervention. And we also know that you can spread that out over once a week for over a period of weeks and get the same results. Okay, so we said, all right, but some of these parents were not actually improving, even though overall this was a very, very successful outcome. Some of the parents weren't, and it seemed to be that the parents who were not showing these improvements were the parents of the kids with the most serious suicide attempts. So my colleagues, Melanie Harned, Perry Hoffman, and I went about doing a large study looking at parents of children, ages really of any age, but primarily teens and young adults, to investigate, well, what's the experience of parents whose kids have made suicide attempts or are engaging in severe and likely dangerous self-harming behaviors. Well, it turns out that parents, in fact, reported being terrified and suffered from either acute stress disorder or PTSD. In fact, in our current study, we looked at 432 parents, and 96.5%, so almost all of them, reported intense fear, helplessness, and described things like feeling horror with intrusive memories and thoughts and images in response to their children's suicide attempts. 95% of them could be classified with acute stress disorder, and half of them met criteria for post-traumatic stress disorder, full criteria, where the index trauma was their child's suicide attempt. So this tells us that not only is there reciprocity, but kids who are really struggling in a very big way to the point of suicidality are having a very big impact on their parents, who are being sidelined. They're being so negatively affected. We hypothesize that it's not only are they suffering themselves, but they're not as available to their kids. So that this is one of those negative reciprocity situations where they're struggling and they're doing things, the kids' suicide attempts make the things worse, but then how they respond is they're overwhelmed and they have PTSD, and they are now not able to respond as successfully to their kids and help their kids. So we set out to create a new version of our program that would actually start to address these particular problems. So this is a new program that we started just 3 years ago for parents with traumatic responses to their child's suicide attempts. We limited our particular study to parents with kids ages 15 to 35. This teenage, young adult range where there's a lot of contact between parents and kids, and they're likely to be living together. We built on our original Family Connections program. We didn't eliminate any of the skills there, but because the focus is on suicidality and the index problem is suicidality, we weren't as concerned about borderline personality disorder. However, the vast majority of these situations, the child age 15 to 35 is still meeting criteria for borderline personality disorder or many of the traits of borderline personality disorder. So this allows us to also intervene earlier to identify BPD. Another way of thinking about using suicidality as an index or marker is to say, you know, for teens who have not received a borderline personality disorder diagnosis, their first referral to the mental health system, to an emergency ward or to a mental health treatment center is likely because of a suicide attempt or at least a suicide plan. Many professionals are reluctant to give a diagnosis of borderline personality disorder to a teen, although teens certainly can meet the criteria. By focusing on suicidality, our hope is that we're actually catching kids earlier in the process and their families earlier in the process, because when we look at our data with Family Connections, we find that often it takes 7 to 10 years before young people get the accurate diagnosis and end up with the accurate evidence-based care, say dialectical behavior therapy, for borderline personality disorder. And those many years of treatment focus on the co-occurring problems like depression, anxiety, PTSD, substance use disorders, eating disorders, ADHD, and so forth, that are underneath the borderline personality disorder umbrella, meaning that they're all problems of emotion dysregulation. But people who meet the criteria for 5 or 6 or 7 or more diagnoses, in our conceptualization, don't have 5 or 6 or 7 different problems, but rather the core problem of emotion dysregulation that shows itself in a variety of different ways. By focusing on suicidality, we can catch individuals and families earlier so that they don't wait for 7 to 10 years before they get the help that they need. Our new program, which we call Family Connections Managing Suicidality and Trauma Recovery, recognizes that parents actually experience acute stress disorder and PTSD when their kids are suicidal. And so we build on the Family Connections skills, and we add additional skills to address their fear and their PTSD. And it helps them to reduce their trauma-related problems. That's the idea. So we've incorporated new skills. For example, parents whose kids have made suicide attempts often bring with them a conditioned fear response. So now their kid might be doing better. Their 15-year-old, their 20-year-old might just be a little bit unhappy, have a bad day at school, have a negative interaction with a friend, but is not at all suicidal, not at all suicidal. But parents with this trauma history can get an enormous bump in their fear, and then one of two things is more likely to happen. Either that fear causes them to withdraw and be unavailable to their child in an ordinary situation where their child could use their support, or the parent tries to control the situation and tries to start to put limits on kids that maybe developmentally are problematic. And that, of course, both of those have a negative impact on the relationship between the parent and the child. And then if the child develops more distress, perhaps does become suicidal, the poor relationship can be a contributor to that, or the absence of the parent can be a contributor to that. And at the very least, the parent's not available in a helpful way. And the parent, of course, suffers more. So again, I hope you can hear that I'm not blaming the person with BPD, the child, and I'm not blaming the parent. These are painful, difficult experiences for everybody. So our program is designed explicitly to give them some new things to do and to give them a break. So we're teaching parents both individual skills, how to manage their own distress, their grief, their burden, their depression, but now also their fear and their stress, to reduce that so that they can, in fact, use their parent skills in a more effective way that's good for them and good for their loved one. So the good news is we have some early data that I want to tell you about. We've now evaluated our program with 160 parents, and we're curious, of course, if we're able, if it would be possible to get these very distressed parents with high rates of PTSD into such a program. And indeed, we were. These parents are so unhappy, they're suffering, they really want to do a better job as parents, and they of course want to not feel so stressed and burdened themselves. Just like our earlier study, about half met full criteria for PTSD, and another 20% almost met full criteria for PTSD, and 100% had acute stress. Very high levels of grief, depression, anxiety, and burden. So we took on this program and we've delivered it now in 4 different sites across the United States and Canada with 160 participants. So we're pretty sure this is a decent and representative sample. And what we found was from pre to post, and then we follow them up 3 months later, and we're in the process of doing a 1-year follow-up, which we have not yet finished. But our 3-month post-intervention data tell us that indeed parents report significantly decreased post-traumatic stress disorder using the PTSD checklist and some other ways of measuring trauma-related problems. Significantly improved or reduced depression, significantly reduced anxiety, stress, and burden. So all of these things are moving in the right direction. I would add, by the way, that depression, anxiety, burden are not in the normal range because their kids are still struggling, but they're way down. They're much closer to the normal range and much more like the range that one would expect of anybody whose loved one is struggling, but not in the range where it's so overwhelming. We also found, as we did in ordinary family connections, increased mastery and empowerment in these parents, and overall, significantly improved family functioning. Now, what we don't know yet, because this will be the next study, is, in fact, what happens to their kids? Do these kids notice this? Is their experience of their parents improved? Is their experience of family functioning improved? And then over time, does this in fact have an impact on their suicidality? Now, as you probably know, that's more of an epidemiological question. That's a tough one because you need a very large sample because the actual rate of suicide attempts, even in a very suicidal sample, is still low. You have to have a very large sample. So our next study is going to have hundreds and hundreds of parents, and we'll be able to track their kids to see if, in fact, they are less suicidal or in the coming year. They are, in fact, going to the emergency ward less often, and if they are, in fact, less suicidal. So we can now draw some conclusions. These data together tell us that it's very useful to intervene early with parents and families and to teach parents and teens skills, that we can do either one and get benefits. We clearly can teach parents skills, partner skills, and that's good for them and does have a reciprocal benefit for the person with BPD. We can also give good treatment to people with BPD, and that in general has a positive impact on their loved ones, their parents or their partners, and on their relationships. However, that if we work on both sides of these reciprocal relationships, we can have an even bigger impact. So there are clear benefits for the parent and clear benefits for parents and partners. And we've seen this repeatedly. We also know unequivocally through study after study after study that parents and partners and families are relevant to patient outcomes. Patient outcomes are also relevant to families, and this provides strong support for our transactional model. But not just being a theoretical point, I want to emphasize that most treatments for people with severe disorders are individual treatments. We still, at least in North America, we still provide family interventions a very small percentage of the time, not only for borderline personality disorder, but also for any other severe disorder, including suicidality. Armida will later talk about a new program that she and her team have been developing for younger kids and their parents, and how important that is there. I want to emphasize how important this is for people of all ages, not just teens and young adults, but middle-aged people and older people, that actually when one person is suffering, other people are suffering, and that reduces their skills at being able to help each other. And so providing family interventions simultaneously when we provide individual interventions is a very humane thing to do that's good for both sides of the transaction. So family functioning is central to suicidality and self-harm. It actually mediates it. What that means is if we don't intervene with families, if we can't help family functioning improve, we're really putting blocks in the way of individuals overcoming their suicidality. Or to put it in a more positive way, if we can improve family functioning, we're removing things and making it easier for individuals to get better and to reduce their suicidality and to be safer. We know that intervening with parents and couples and families in a skill-based model, whether that's in a clinic or family connections, that parent and family skills actually are extremely efficient and have very big effect sizes, meaning a small amount of resources, not a lot of time. They can be done in groups. It doesn't have to be done one family at a time. So very few resources has an enormous impact if placed in the right place. And we know that the mechanism for improvement for people who are suicidal and with borderline personality disorder includes their families. Specifically, if loved ones like parents and partners can improve their validating and be more invalidating and reduce their invalidating responses, that actually can have a big impact, especially on teen and young adult outcomes. Okay, so in the future, we've got to evaluate more patient outcomes with our new suicidality and trauma recovery program, because we don't know whether, in fact, yet, whether suicide rates or suicide attempting rates go down. We know that relationships improved and well-being improved, but we don't know about suicidality. That's going to take a larger sample and a longer period of follow-up. We don't know which problems are most effective. We know that emotion dysregulation goes down. We know that depression goes down in the kids. We need a longer-term evaluation in general. We know that 3 months later or 6 months later, things either maintain or even continue to get better, but we don't know what happens after a year or 2 years. We need longer follow-ups to see what happens. We also need to identify what the right dose of intervention, dose in this case would mean how intensely, how many sessions, how much time, how much practice people need to have the best impact. We know that doing these things in groups, because that's primarily what we've done, is efficient. What we don't know is, gee, if we did it for longer, or if we had booster sessions, if that would be better. Or maybe we don't need to do 20 hours of intervention. Maybe we only need 10 hours of intervention. I'm a little skeptical that that's true, but it could be true, and we don't know until we evaluate them. And then finally, we have to evaluate DBT parent skills as prevention and to augment prevention, not to intervene so late when kids are already suicidal, when they're already self-harming, but actually start to think about intervening earlier with parents, not only in clinics after kids are referred to us, but out in the community, in schools, in community centers, in other places, for parents to learn these skills before their kids develop such severe problems. We have some good evidence that these skills in schools, because I haven't talked about this, but we started to implement a school-based parent program, that actually parents can learn these skills extremely well, even if their kids aren't in the mental health system yet. There seem to be good improvements there. That study's too small for me to talk about just yet, but those kinds of data need to be collected as prevention. Okay, I just want to end by saying I couldn't obviously have done these studies myself. These are my much appreciated colleagues and friends that work with me on these various studies. And again, happy to send them along, or you can find them in your academic library. Okay, so I think we have time for a few questions, right?
We expect rather to have questions on chat, but I would ask the question in meantime. Having very limited resources for the teenagers, for intervention like we having here, would you say that for teenager case, would you give priority either or, like focus on individual intervention or family intervention, parent intervention in suicidality? How would you say, like, you know, being very limited?
That's a great question. I think that once we have suicidality present, I don't think we yet have data to tell us that only intervening with the parent is going to be sufficient. They're probably, because it's going to take a while for the parent to start to learn skills and build those skills into their family. And the idea would be not to leave that kid alone who's suicidal. So it depends on where the child is. If the child is doing okay, starting to struggle, then if you don't have enough resources to do both, you could start with parents. But if the child is really struggling to the point of suicidality or self-harm, you couldn't do both. You'd start with the individual. Mm-hmm. We know that the individual interventions work with kids, and Armida will tell you about some of the mixed combination of individual and family work that even with younger children is effective. With younger children, you probably can't just do one or the other. I would argue that with limited resources that we try to do both, although that of course contradicts the idea of limited resources. The hope is that by intervening early enough, we are extremely efficient and can intervene just with families.
Mm-hmm. My next question refers to the same limited resources. When we have the same model, I would say, of individual care, individual consultation or psychotherapy, then we have individual therapists, and then the family is coming in the picture, asking for support in the suicidal crisis. And then the question is that many therapists in Poland struggle. If the same person is able or should support parents, or they should be sent someone else?
That's a great question that comes up everywhere. And there are very strong opinions about this, but it turns out, let me just talk about the data. The data say it doesn't matter. The outcomes are not better or worse if it's the same therapist or if it's a different therapist. You could imagine there being some maybe easier advantages if you have different people in one way, because you have an advocate for the child, you have an advocate for the parents, but of course we don't want them clashing. But it might be, if they're both experiencing a crisis at the same time, if you've got two therapists, they can both help. On the other hand, the therapist who does both has the understanding and the knowledge of both patterns and can represent that and use that knowledge and understanding in their work. So we've looked at this. We've not done a randomized trial where we've said, okay, same therapist does both or two therapists do both, but we have done programs one way and programs the other way and find no difference in outcomes. Some therapists prefer to do it one way and others prefer to do it a different way. But the data tell us that both are effective. That's good news. So do what you like, is the answer.
Yeah, I think this is the flexibility that
Right.
DBT gives us.
That's right.
Keeping our rules of doing therapy. Okay, we have some comments on chat. I'll just share with you. There is one mother. Thank you for the comment. Who participated in a DBT training with her daughter participated 15 years old, and her suicidal ideation dropped more than 90%, like she noticing that. Then we have a comment that Polish therapists don't want to give a diagnosis of BPD early. And then there is a question, how to intervene as a child psychologist in a DBT way at school in case parents are abusive and aren't responsive for psychological advice. Do we have any efficient way to prevent suicidality in teenagers in kind of this case, or just to limit the psychological damage at the home? So if we are psychologists at school and the parents are not responsive to our invitation of cooperation.
Right. That's such a hard situation. And of course, it depends on what the psychologist is doing in the school. These data might tell us that as hard as it might be to find a way to connect with the parent, even if they're difficult, it's beyond the amount of time that we have. But if you have to imagine Magda and I doing a role play where she's being belligerent, but I remember these data and I can say something like, gee, Magda, this is so scary. It's so awful that your child is, suicidal or self-harming, and you must just be overwhelmed. And actually spend some time just communicating that we understand and that it's a burden for the parent and that we're not blaming the parent for this. It's important to recognize that we did a small study just asking all of our parents in our program. 100% of them had felt either very much or extremely invalidated by a previous mental health professional and blamed for their children's problems prior to coming into our program, where we don't do that. So that's part of, and our dropout rates are around 8 to 10% instead of what in the field is dropout rates of 50 to 60%. So I think this understanding, oh my gosh, this is so awful for you. We know it's terrible for the kid, and we're not going to ignore the kid. We're going to simply try to connect with the parent. I think that's the best thing we can do. And some parents still will not feel connected, won't feel motivated, and there are limits to what we can do in those situations. It's tough in the school in particular because, our roles in schools is pretty narrow, right? So at least here. And I hope I'm addressing the question properly.
Mm-hmm. Mm-hmm. Yeah. I think that different case will be if we have also abusive parents or like with some type of child abuse, then we need to engage some special child protection service and things.
Absolutely.
There's also one important comment that often it happens that when the teenagers, they attempt suicide or they very serious self-destruction crisis, their parents, they find out, or whoever find out, that they haven't even realized how serious their kids are facing serious serious problem at school. So do you think, in other words, that the main problem is the communication between parents and children, that the parents are not aware where the children are struggling with and what makes them suicidal?
Well, I think that's one way of saying it. I think it's if you go back to the little 2-arrow diagram that I put up early, I would say that our conceptualization is that we have a child in this case who's got pretty severe problems, who's not able to articulate or express those problems in ways that the parent can understand. And the parent is overwhelmed and can't listen or validate in a way that helps the child express it. And they're stuck in this pattern. Communication is certainly not a bad way to talk about that, but I think it's how do I say, at least in North America, when we talk about communication, it often leaves out the role of emotion dysregulation. So I would say absolutely communication, but it's driven by a dysregulated emotional process. The child can't express him or herself well, partly because developmentally they don't have the skill, but partly because they're really dysregulated. And the parent can't hear it, not only because the child's not accurate, but also because the parent gets dysregulated, because it's overwhelming to have a child who's struggling that way. So it's communication, but the emotion has to be managed by at least one side of that before the communication is going to improve.
Okay, yeah, thanks. There is a comment on that, and I think it's also worth to address the comment from Marta, who is saying that she has few years experience with mental health support system in Poland. And it seems from what you are saying that there should be a therapist who is multitasking, multi-roles, like parents-oriented, child-oriented, child support system-oriented, that it's very difficult to find a person like that, or to function for us. It may be a challenge for us.
Absolutely right. I don't know how your system runs, but that's certain. What you just said certainly could describe, the schools that are within a half a kilometer of where I'm sitting. Right, they're quite the same. So, but I don't want to overwhelm you thinking that the solution is so difficult. I think these data tell us that we can have a big impact very quickly. And we also know that we can train people to do this very quickly. Magda organized a family connections training, and over the course of two-part days. Sorry, thank you. Parts of 3 days that actually I think gave people lots of skills to interact with parents. They already probably had some skills to interact with kids, or if they already are good with parents, then we can teach them some skills that they can provide to kids. And that's what we do in our DBT in schools programs.
Mm-hmm. Yeah.
So it's big, and you're right, and it's not as resource intensive if we think, oh, what do we need to train people in? Oh, okay, it's possible to do this fairly efficiently.
Yeah, I think it reminds me discussion about using resources. Either we go for like treatment as usual and then try different paths, like time after time after time after time, finding things not working, and we're hoping that that at some point things will change, and we're waiting, or using extensive intervention in shorter time.
Right.
It makes sense with especially younger people. And there's one question I missed. Thank you for reminding me, Magdalena. What in the situation when a family wants to participate and engage in the therapy or intervention program, but the patient or teenager that does not want, is saying, no, I don't want, or I don't want you to step in?
Well, I mean, it turns out that parents are usually adults and can actually make those decisions even if their kids don't want them to. And of course, should participate anyway. I mean, I think it's important. So the short answer is, well, of course you'd go anyway because it's useful. But the slightly more complex answer is to validate, like, gee, Magda, what are you worried about? What makes you, what makes you worried about me doing this? Do you think I'm not going to talk about you, not in any negative or pejorative way. I'm going to try to learn some skills. I want to do a better job. And I understand and then try to like, why do you want me not, why would you want me not to do this? And usually it's a misunderstanding of what this is going to be. This is going to be a bunch of parents sitting around and complaining about their kids. Of course, the child doesn't want you to do that. But when they find out, gee, I'm going because I want to learn how to do a better job. It's good for me, but hopefully it's going to be good for you too. Very few people are, well, they might still say, I don't want you to do it, but parents should still do it, of course. You know, it's like saying, you know, I don't like your friend so-and-so. I don't want you to, you know, the kid says, your child tells you that, say, well, you know, you don't have to spend time with my friend, but I'm going to go have coffee with my friend. You don't have to explain it or excuse it. You do it. You're a grown-up. You can make those decisions. Now, if it affects the kid directly, of course, then including the kid in the process is important.
Okay. Okay.
Okay.
Okay. So I think this is just the time, and this is the last question. And I think it's important. Is DBT, but it's BPD, it's borderline personality disorder. Is it treatable? Is it treatable? What would we say?
Well, the data would certainly tell us that it is. You know, so for example, in the study that I showed you of young adults, the transitional youth 18 to 25, I think 80% of the patients in that study did not meet criteria for BPD at the end of treatment. That's pretty treatable. I mean, we know that borderline personality disorder left untreated comes and goes as a diagnosis, but that the stress stays present. However, good treatment, and there aren't too many of them, but the good treatment successfully treats people, and then the relapse rates are pretty low. And people, I mean, you know, about half of outpatients in DBT, about half at the end of a year of treatment end up in having an ordinary life. They end up in school, at work, in close relationships, not going to hospital, and so forth. After 2 years, that number seems to go up to around 2/3. So that's including the dropouts and everything, you know. So yeah, now it's a lousy treatment for the third that it doesn't help, okay, but it's a good treatment for those that it does, and that, so yes, so for between half and 2/3 of people, BPD is completely treatable, and people don't have it anymore.
Okay. Yes. This was the last question. There are a couple more coming, but I think the question are the signs that the indicators that participants are interested in the topic. And I think we can invite to our recordings, our workshop, our trainings to get interested in family connection program, that you will find lots of answers of how DBT, how family connection, how working with families works actually for adolescents. So I think we'll stop here for the question and invite everyone to self-study, to dive into DBT and family connection to find more answers. Thank you very much, Alan.
Well, thanks so much for having me, and I hope this has been useful. It's a lot of fun for me to get to walk through these various steps that we've taken. So thanks. Enjoy your day.
Thank you. I just want to remind everyone that Alan, who is our guest today, he is doing this talk with us as a colleague, as a supporter, without receiving any honorarium for that. And thank you for supporting us in this.
Oh, of course. I'm delighted. Yeah.
Okay. Thank you very much. Thank you.
Take care. Thank you, everybody.
Thank you. Bye.